Okay, hi guys. So we're just going to start. Can you all see my screen? If anyone can unmute and say, or
just put in the chat.
Yes, we can.
Okay, perfect. Thanks. Okay, so we're just gonna. My name is Prithi, and this is Qiaoqiao, and we're just going to go through some of the basic things that you should know for interpreting imaging and things like that in Mod A. So this is just the basics, basically. Okay, so what we're covering today is chest X-rays, ECGs, and ABGs, and we'll have some questions throughout, and then just a case at the end as well. Okay, so to start off with, when you're doing any imaging interpretations, I'm sure you guys have probably had some lectures on this already, but it's just really important, even in OSCEs, to make sure that you're checking all the patient's details, the full name, date of birth, and either the hospital number or the NHS number, the date and the time the film was taken, and any imaging that they've had previously, so you can use that for comparison. Often you're not going to have this in, for example, like an OSCE scenario, but it's good to just say that you would look for this in a real life situation. And then with any imaging, it's important to take a systematic approach because a lot of the time there can be subtle differences, especially when you're first starting to do interpretation, that you might miss when you're trying to interpret imaging. So taking a systematic approach with any imaging is really important. And the particular one we use for chest X-rays is RIPE ABCDE. And I'll just go through that in a bit more detail. Also, if you have any questions throughout, please just unmute and just ask and we'll try and help, or just pop it in the Q&A section. Okay, so to start off with RIPE, after you've gone through the patient details, R is for rotation. And what you want to do is check that the clavicles here and here are equidistant from the spinous process. And this basically ensures that
Can you see your mouse?
Yeah. Okay. And this just makes sure that the patient isn't rotated to one side or the other, so their shoulder isn't in the way or more forward on one side, and because this can distort the way that the lung fields and things like that look. So if they are equidistant, then you can be sure that the patient is facing straight forward in front of the X-ray machine. So I is for inspiration. And this is to make sure that the patient is taking a deep breath in when the X-ray is being taken, because we want them to have taken a deep breath in to ensure that we can see the full lung fields clearly. And we do this by ensuring that there's 5 to 6 or more ribs seen anterior. So that would be at the back. So these ones here, you would count. So that's 3, 4, 5, 6, 7. You can see. Sorry. So yeah, and then P is for penetration or for projection. So starting off with for penetration, we just want to make sure that the X-ray doesn't look too white or too dark. In the next slide, I'll show you some images that are just not well taken. So you can comment on that as well. And projection is basically whether the image is PA or AP. And that means if it's PA, which is what is mostly done, it means that the X-ray machine is behind the patient. And most of the time, this is how the X-rays are taken. And the only situations where it might not be is if, for example, in A&E, if the patient is very unwell and they can't get to an X-ray machine or walk, they might take it while the patient's lying down in bed from front, and then that would be an AP image. And it's important to know if it's AP or PA, because in AP, the heart can look bigger than it actually is because it's the more anterior structure in the chest. So it's important to know. And finally, in RIPE is exposure, and that's just to make sure that we can see enough of the chest, basically. So we want to be able to see the full lung fields, the trachea, the clavicles, and also the diaphragm at the bottom, because we want to see the costophrenic angles, which is important because in some pathologies, fluid can build up at the bottom of the lungs, and that can distort the angles, and it might give an indication of what's going on. And yeah, that's it for RIPE. And another thing just to note is because of the way the heart is located or positioned in the chest, the right side the right heart border on the X-ray is actually the right atrium, but the left heart border on the X-ray is the left ventricle. And that's just something to bear in mind in case there are any enlargement. You can see, and you'll be able to see which, basically, anatomy-wise, what part of it is being enlarged. One other thing is, in terms of anatomy, you'll remember in second year or first year, the lungs are divided up into lobes, but in an X-ray, it's not always easy to see the different lobes. So what we do is divide it into 3 segments, and we divide it into the upper zone, middle zone, and lower zone. And that's how you kind of locate where you can see opacifications or things. So for example, you might be like, there's consolidation in the left middle zone instead of lobe. Okay, so any questions? Yeah, please feel free to ask. These are just some images of poorly taken X-rays. So you can see a bit of rotation here, poor exposure, so you can't see the full lung field, it's cut off. It's too dark over here, so you can't really see the lung fields properly. And this patient's lungs look a lot smaller than what you would expect, because they haven't adequately inspired. Okay, so moving on to ABCDE. A is for the airway, so we want to make sure that the trachea is central. It can be slightly deviated to the right, and that is normal. But if it's significantly deviated, you'll be able to tell that it is. Otherwise, it is normal to be a little bit to the right. You want to check that there's no foreign bodies that you can see. And then moving down the trachea, you want to see the carina, which is the bifurcation of the trachea, where it divides into the left and right main bronchus, which you can see here. And if the X-ray is well taken and adequately exposed, you should be able to see it. And moving down is the hilar structures, which is here. And that is the main pulmonary vasculature in the lungs. So it does appear a little bit more dense than the other areas of the lungs, even in normal chest X-rays. But if it is significantly more dense, it could suggest different pathology. They're usually the same size. So if there is asymmetry, it could suggest pathology. And often the left side is a little bit higher up than the right. An important pathology to remember in 4th year is sarcoidosis, which presents with bilaterally symmetrical enlargement in the hilar. But if it is unilateral asymmetrical, that could suggest a malignancy. And another thing I forgot to mention is with tracheal deviation, if there's only certain things that either push or pull the trachea in either direction. So something that would push the trachea away from the midline would be a tension pneumothorax, which is high pressure entrapment of the air that builds up, and it causes mediastinal shift, and it pushes the trachea away. And that's in comparison to lung collapse, which is a sudden loss of air, so the trachea will be pulled towards wherever the lung has collapsed. And yeah, that's just another thing to make sure you remember, is to always make sure that the patient isn't rotated, because that can distort the way that the trachea looks, and it could just look deviated even when it's not. Okay, so moving on to B is breathing, and that's essentially just looking at the lung fields, the main bulk of the chest X-ray. We want to make sure that you can see lung markings throughout, right up until the edges of the lung fields, which is these white wispy bits. I think initially when you look at chest X-rays, they do look like it's something abnormal, but a lot of these are just normal blood vessels that you can see. And if there is more density, then you'll be able to tell that there's something going on. So you can note any asymmetry between the two. And a good way to make sure you don't miss any lung markings is just to trace your way around the lung fields, because often when you're doing OSCE practice, and some stations come up and there's a small pneumothorax that you won't be able to tell if you don't do that, and it might be like at the top of the lung, you'll miss it. So yeah, that's just a good way that we've been told to look through. considering lesions will just be areas of opacification. They're usually quite obvious to see. So it could be indicating some kind of infection or a tumor. And often the location of the opacification can indicate or point you in a different direction to what pathology might be underlying. So, for example, in TB, they usually occur in the apices of the lungs, and that's because a lot of the air kind of pockets are at the top. And at the bottom, the last thing is the costophrenic angles again, because the fluid can build up and blunt this angle. But yeah, I'll talk about that more a bit later on. And the pleura, which is surrounding the lung fields, that's usually not seen in healthy individuals. And so if there is any thickening, it could indicate some kind of pathology, particularly mesothelioma is a common one with thickened pleura. And yeah, I would always say, make sure you describe what you're seeing before you jump into trying to find out diagnosis, because often in OSCE mark schemes, the description is worth a lot more marks than just the diagnosis. Okay, so does anyone feel like they can figure out what's wrong with this chest X-ray? Feel free to unmute or put it in the Q&A bit. No. Okay, so I'll just go through it. I think it's the first one. So you can see that if you look at the lung markings here, you can see that the white wispy bits kind of go all the way up until the end of the left lung field, but here they kind of stop. So you can see that there's an outline here, which shows that there is a pneumothorax in the right side. Okay. Right, moving on to cardiac. This is just to make sure that the size of the heart is no more than 50% of the thoracic width. So we often call that the cardiothoracic ratio, and you might hear that a lot in during your rest rotation. And if it is more than 50%, as it is in this X-ray here, we would class that as cardiomegaly. And there's a lot of different causes for cardiomegaly, and some could be valvular heart disease, cardiomyopathy, pulmonary hypertension, pericardial effusion. There's quite a few things that can result in cardiomegaly. So it's an important feature to identify if you do see it in your chest X-rays. And dextrocardia is just one of those weird things that you'll see on PassMed, and it just means that the heart is flipped within the chest. So the right's on the left and the left's on the right. Okay, and moving on to diaphragm. We divide up the diaphragm into the left and right hemidiaphragm, and we look at this, like I said, because of the costophrenic angles. So the right is usually is often higher than the left, and that's because of the presence of the liver, which pushes up the right hemidiaphragm, and that's normal. But there might be a gas bubble under the left, because that is where the stomach sits, and that's normal. But it's an important thing to be able to differentiate between a gastric bubble and just free air under the diaphragm, because free air could indicate some kind of perforation, but that is a Mod B gastro kind of thing, so you'll probably get more teaching on that later on. It might just be something to be aware of for now. So yeah, the costophrenic angles, you want to see if they are sharp or blunted, and just see if they just look like a well-defined acute angle is mainly what you're looking for. And finally, everything else. So this is anything else in the X-ray that you think is a bit weird or probably should be noted. So any soft tissue swelling, any breaks in bones, any medical devices like pacemakers, NG tubes, ECGs, all of that, even though it might seem like it's not relevant to whatever OSCE station, it probably will give you marks if you do explain, like this pacemaker here. You can see. And can anyone see something in this X-ray that comes under the everything else criteria? Does anyone want to venture out and try and figure it out? Oh yeah, we'll just check the chat as well. No. Okay, that's fine. So there's a break in the clavicle here, and that could be missed if you don't go through everything else. And so that's important because, for example, if there's a break in a rib or something, it could puncture the lung, and that could indicate towards whatever symptoms the patient is having. Okay, so if you guys, so this is just a summary. I'll just, I can present this X-ray to you guys just so you can see kind of how it should be done in OSCEs. I think it was quite useful to hear that when we were in your position last year, because you kind of just want to hear what you can say and then just kind of replicate that and just keep a structure in mind. You'll kind of pick up your own style of presenting as you do more. So yeah, it's just kind of about practice. By the end of the year, you'll all be able to do it. So the details for the patient are down here. So this is a chest X-ray of John Doe, date of birth 1st of the 1st, 1950, MRN 123456, taken on the 17th of October 2023 at 11:30 a.m. It's a PA film with minimal rotation because the clavicles are equidistant from the spinous process. Adequate inspiration because we can see at least 6 ribs. The penetration and exposure is also fine because we can see the clavicles and we can clearly see the diaphragm. So going on to the airway, the trachea appears to be central and not deviated. The carina is visible and unremarkable. We can see the hilar, and the right seems to be normal, but the left, there is a mass obscuring this region. So moving on to breathing, there's lung markings present throughout, as we can see, white wispy bits throughout. But there is, again, a large single irregular rounded mass in the left parahilar region. And other than that, you can't see the pleura, so it's unremarkable. And in terms of cardiac, the cardiothoracic ratio is less than 0.5, indicating there's no cardiomegaly, and the heart borders appear to be unremarkable as well. So diaphragm, the diaphragm and the costophrenic angles are unremarkable. You can see the acute angles right here. There's no fractures in any of the bones. We can see no soft tissue swelling and no other medical devices seen on the chest X-ray. So in summary, this is an erect PA chest X-ray with a single large irregular mass in the left perihilar region. Does anyone want to venture and give a diagnosis that they might think? It's a 73-year-old man with a persistent non-productive cough for 2 months. It's all right if you get it wrong, it's fine. We really didn't know anything at this time last year either. So if anyone wants to guess.
Is it lung cancer?
Yeah, it is, yeah. Thanks for answering. Yeah, it is. So lung cancer is one of the ones that the med school really wants everyone to kind of pick up on. A lot of the cancers, so knowing that it's a 2-week wait referral. So non-productive cough, probably suggesting not an infection or something like that, and the long history as well. Okay, so if you guys can go to Menti and log in or put in the code. I just realized I got rid of the code, so let me just type it in for you guys.
No, it's on the slide.
Yep, I stopped sharing.
Oh.
It's 81. Oh wait, let me just share this actually. Okay, yeah, the code should be on there, 818980.
Can we see how many people have joined?
Yeah, if you guys can just thumbs up once you've joined, it'll help us know how many of you guys on there. Okay, I'll just wait for it to get to like 10.
It's fine.
Okay, we'll just start. Okay, so if you guys can see the chest X-ray, just take a guess at what you think it would be.
Are you hitting the result?
Yeah, there's one more person. Okay, great. So let me show you. Okay, great. Yeah, pneumonia. Fine. I guess you guys don't really need an explanation for that one. It's just the increased opacification on the right side. You can tell. Okay. Okay. Okay, so okay, fine, 50-50 split. So with this one, can you guys still see the X-ray? I'm not sure.
No.
Okay, so I can show you one a bit later on. With this one, the answer is spontaneous pneumothorax because the trachea isn't deviated. And you can see the carina just directly underneath at the midline. So if it was a tension pneumothorax, it would be deviated away from the midline. So that's why it's a spontaneous and not a tension. Okay. So the answer is actually COPD. And the reason for this is that in the X-ray, you can see that there's a lot more, the lungs just look a little bit hyperexpanded. And that often happens with patients with COPD. Yeah, I don't know if we can show you. So because the lungs are quite hyperexpanded, that's what happens when a patient has COPD for a while. And I guess some of you guys thought sarcoid because of the kind of like opacification around the hilar, but yeah, I think it is normal in this X-ray, and the main thing is COPD. So yeah, the more you look at chest x-rays, the more you'll become familiar with what sarcoid will look like. Okay. And I think this might be the last x-ray. Okay, so yeah, it's pleural effusion. And the reason for that is that you can see that there's a large white effusion here on the side, and that's causing blunting of the cosophrenic angles. So with pulmonary edema, it wouldn't be pulmonary edema because you would see more of a bilateral change, and it would be throughout rather than at the bottom, where pleural effusion, the fluid collects at the bottom of the lungs, and that's why the cosophrenic angles are blunted. Okay. And does anyone know any causes of pleural effusions? Yeah, these are all really good. Yeah, great. So yeah, the main thing is to know that they split them into two on PassMed between exudative and transudative causes, and then there's criteria to be met to see whether it's one or the other. It's quite a long list, but it might just be useful to be aware. Okay, so I think we're going to go on to ECGs now. Let me just stop sharing.
Talking about ECGs. So ECGs are basically like a visual recording of the electrical activity that's going on in the heart, and we create it by attaching a number of electrodes to the patient, and that detects the electrical activity from different angles. From that we can have a trace and we can see what's going on. Okay, so the lead placement. So normally we use a 12 lead ECG, but it actually only has 10 leads, but it gives like 12 views of the heart, so that's why it's called 12 lead. So there's 6 chest leads and 4 limb leads, and it's kind of important to remember the placement of each one because they can test you in OSCE stations. So they might ask you to perform an ECG on an actor, so attach all the leads and then interpret the results that you get from it. So chest leads, so V1 is on the 4th intercostal space on the right sternal margin, and then V2 is on the 4th intercostal space on the left sternal margin. And then we normally put V4 next, which is in the 5th intercostal space, mid-clavicular line, and then V3 kind of just goes in between V2 and V4. V5 is on the 5th intercostal space again, but on the anterior axillary line, so that's like here. And then V6 is on the 5th intercostal space, mid-axillary line, so like down the side. And then in terms of limb leads, so there's 4 colours. There's red, yellow, green, and black. And these have to be placed on like the bony bits of each limb. So either you can go like shoulder and hips, or you can go wrists and ankles. So how they taught us to remember it was ride your green bike. So R stands for red and also right hand. So you start with the right hand and you go clockwise. Yeah, so it goes red, ride your green bike. So like red, yellow, green, black. And yeah, so you need to remember that. So we're going to look at we're going to go to like basics. I don't know, when I started 4th year, I didn't remember anything. So we're just going to look at the ECG waveform and look at the components. So this is a picture of a sinus rhythm, so it's like normal. So there's a P wave, a QRS complex, and a T wave. So the P wave represents atrial depolarization. So that is when the atria of the heart contract. The QRS represents ventricular depolarization, which is when the ventricles contract, and T wave is ventricular repolarization, which is when the ventricles relax. When we're interpreting ECGs, other important things to look at is the intervals. So the PR interval, the QRS complex, the QT interval, and also the ST segment, but we'll talk about those a bit more. So this is what an ECG looks like. You get your 12 different leads. I think it's cut off, but like this is 1, 2, 3, and then these ones. And then normally you get what's called a rhythm strip at the bottom, which is normally lead 2, and it's just lead 2 for 10 seconds. So it's easier to work out things like rate and rhythm. So I'm going to talk about how to approach interpreting one, because I think it looks quite difficult if you just look at it for the first time. So I start off. So for OSCEs, even when you're in a station where there's not a patient or an actor pretending to be a patient, it's still good to introduce who you are and what you're going to do. So you say, hi, my name is Qiaoqiao, I'm a 4th year medical student, and I'm here to interpret this ECG. Next, I want to check that I'm looking at the right ECG for the patient. So I'll check that using name, date of birth, or MRN number. I also want to check when this ECG trace was taken. So I'm not looking at an old one, or I'm looking at the most recent one. And also I want to just check that the speed and the amplitude is like the standard. So normally the standard speed is 25 millimeters per second and the amplitude is 10 millimeters per millivolts. And that's usually found at the bottom. So then the next thing we want to look at is the rate. So the ECG paper is divided into grids. There's small squares and big squares. And as we said before, the standard paper speed is 25 millimeters per second. So one small square, which is 1 millimeter, is 0.04 seconds or 40 milliseconds. And a large square is 5 millimeters or 200 milliseconds. I never remembered that. You either remember the time or the squares when looking at the intervals and stuff. So I don't know what's easier, just choose one. So then we need to examine whether the rhythm is regular or irregular. So if we look at the screen now, the top strip, looking at the QRS complexes, so the spikes, they're like evenly spaced out, whereas on the bottom strip, the distances between them kind of vary. So that we can say that the top one has a regular rhythm and the bottom one has an irregular rhythm. So if it has a regular rhythm, you work out the rate by dividing 300 by the number of large squares between each R wave. So like in this case, it's around 3.5 big squares between each R wave. So the rate would be 300 divided by 3.5, which is roughly 85 beats per minute, which is normal. If it's irregular, you can't do that because the number of big squares between each complex changes. So instead, you would go use your rhythm strip at the bottom, and you'd count the number of R waves you can see, and then times that by 6. So in this one, it's 17. So 17 times 6 is 102 beats per minute. Another thing to mention is you want to see whether it's in sinus rhythm or not. Sinus rhythm is when there's a P wave before every QRS complex. And yeah, you just want to comment on that too. So then you want to look at rhythm again. We've already decided whether our rhythm is regular or irregular. And if it's irregular, there's regularly irregular and irregularly irregular. So regularly irregular is when there's when it's irregular, but it's irregular in a pattern. So an example of that, as you can see on the slide, is atrial flutter. So it's not normal sinus rhythm, but it's regularly not normal. So it's regularly irregular. And irregularly irregular would be when there's no pattern and it's just chaos. And a good example of that is atrial fibrillation. Yeah, that one's an important one to know. So after that, you want to look at the axis. So the axis of the is basically the sum of all the electrical activity in the heart. And the normal axis is when the QRS axis, is between -30 and +90. So if you look at this, it's like the pink bit of the circle. And that's because the left ventricle makes up most of the heart muscle. So the normal axis is directed downwards and also slightly to the left. Abnormal deviation indicates that there might be something wrong with the heart. So there's left axis deviation, which is when it's less than -30, or right axis deviation when it's more than 90 degrees. And there's extreme axis deviation, which is between -90 and 180, but I don't think that ever comes up. Yeah. So the easiest way to try and think about this and estimate the axis is, I think, the quadrant method. So you look at lead 1 and lead AVF, and so you look at the QRS complex in those two leads, and you want to determine if they are positive isoelectric or equiphasic or negative. So basically, if the R wave is bigger than the S wave, so it goes more up than down, or it's the same, or it goes more down than up, which is negative. In normal axes, they're both positive. So a positive QRS means that the axis is roughly in the same direction as lead 1. So if in lead 1 it's positive, it means it roughly goes in the same direction as lead 1. And if it's positive in AVF, then it means it's roughly going in the same direction as AVF. So if it's positive in both, the axis will be where they overlap. So it will be in this lower quadrant, which is normal. So using that same kind of logic, you can work out like what left axis deviation and right axis deviation would look like. So if lead 1 is positive and lead AVF is negative, then that's left axis deviation. And if lead 1 is negative and lead AVF is positive, then there's right axis deviation. And one way to remember, they told us, is like left leaving and right reaching. So in left axis deviation, lead 1 is positive and lead AVF is negative. So the QRS complexes are like facing away from each other. So they are leaving. And then in right axis deviation, lead 1 is negative, so it's going downwards, and lead AVF is positive, so it goes upwards, so it's like reaching. Might help you remember. And the next thing you want to look at is the P waves. So you want to see if they're there, what do they look like? So if they're monophasic or biphasic, which basically just means, is it got like 2 peaks or 1 peak? You want to look at if it's flattened or tall as well. So P mitrale is an example of when you would get a biphasic P wave. So that's a sign of left atrial enlargement, and it's often caused by mitral stenosis. And then P. pulmonale is a sign of right atrial enlargement, which is often caused by pulmonary hypertension. And we can see that the P wave is tall and peaked. If the P waves are absent, we want to know, is there any electrical activity? So there could be sawtooth baseline, which is like flutter waves, as you can see here in atrial flutter. Or if there's like a chaotic baseline, then it's fibrillation waves, like in atrial fibrillation. And if there's a flat line, then there's no atrial activity. And you always want to remember, if there are no P waves and the rhythm is irregularly irregular, then that's highly likely that it's atrial fibrillation. And then you want to look at the QRS complex. You essentially want to look at the width and the height. So you want to know if it's narrow or broad in terms of the width. So narrow is less than 0.12 seconds or less than 3 small squares. So this is when the impulse, the electrical impulse would be conducted down the bundle of His and the Purkinje fibers to the ventricles, which is how it should be going. And this would result in a synchronized, the ventricles contracting in synchronous. However, if it's broad, it means that there's an abnormal depolarization and it's not following this normal conduction pathway. So, for example, in a ventricular ectopic, where the impulse would spread slowly across the myocardium from the focus instead of down the normal conduction pathway, there would be a broad QRS complex, whereas in an atrial ectopic, it would still follow down the bundle of His, so you would get a narrow QRS complex. Bundle branch block could also result in a broad QRS complex because the impulse gets to one ventricle down the conduction system and then it spreads to the other side. So it would result in they could also be described as small or tall. So tall would be more than 3 small squares and it shows left ventricular hypertrophy. However, in tall, slim people, they may also have that, so it could be just normal. Then looking at the T waves, so tall tented T waves are associated with like hyperkalemia, also in ST elevated myocardial infarctions, and this is when they are over 5 millimeters in the limb leads and over 10 millimeters in the chest leads. Inverted T waves are normal in leads V1 and 3. However, if they're inverted in other leads, then it's a non-specific sign of other conditions. For example, ischemia, bundle branch block, PEs, or left ventricular hypertrophy. Biphasic T waves are a sign of ischemia and also hypokalemia. Flattened T waves are a non-specific sign, again, is associated with ischemia. So a lot of them are just associated with ischemia. This is what you want to remember. So after looking at all the parts of the wave, you want to look at the intervals. So an important one is the PR interval. So this is the time between the start of the P wave and the start of the QRS complex. So it should be 120 to 200 milliseconds, so 3 to 5 small squares. So you could get a normal one, or a shortened one, or a prolonged one. So a shortened one could either mean that the P wave starts somewhere closer to the AV node than normal, so then the conduction is taking less time. For example, if you have a small atria, or it could mean that the atrial impulse is getting to the ventricle by like a faster shortcut instead of conducting slowly across the atrial wall. So an example of that is an accessory pathway associated with a delta wave in Wolff-Parkinson's-White syndrome, which you can see on this rhythm strip. There's like they call it like a slurred upstroke. So it's like here, and a prolonged PR interval of more than 200 milliseconds suggests that there's some kind of atrial ventricular delay. So for example, AV block, and there's different types of that. So like first degree, second degree, and third degree. The example I think is first degree. You also want to look at the QT interval. So that's the time between the start of the Q wave and the end of the T wave. Long QT interval, they also just call it long QT, has many causes. So there's like some drugs can cause it, like some antidepressants and some antibiotics as well. There are metabolic causes such as hypothermia, hypokalemia, or hypothyroidism, and there are some genetic diseases such as long QT syndrome or Brugada syndrome. And I think it's important to know which drugs cause it because it affects when you're prescribing stuff. You also want to look at the ST segment. So this kind of gives us information about the blood supply to the heart. So the ST segment can be normal or elevated or depressed. ST elevation typically means that there's some kind of infarction. So in the STEMI, there's an elevated segment above the isoelectric line, and this is typically more severe as it indicates transmural muscle death, and this is a medical emergency. ST depression normally indicates some kind of ischemia. You also see it in like digoxin toxicity, and there's like a reverse tick sign. I don't think I can picture it. And also pericarditis. If there is elevated ST segment in all leads, then that's a sign of pericarditis, which is just inflammation around the heart. And then just quickly, so depending where the ST elevation is on the ECG, we can kind of localize where the STEMI is. So if it's in leads, well, you can see from the diagram, but if it's in leads 1, AVL, V5 and V6, then it's a lateral one, and that is the left circumflex artery. And in the inferior leads, that would show that there's a block in the right coronary artery, and if it's anterior septal, then there's probably a block in the left anterior descending artery. So in summary, I feel like that was a lot of information, but I think it's important to familiarise yourself with what a normal ECG looks like, and then you can kind of compare other ECGs to what normal is. And I think like once you look at a few, like keep looking at them, you kind of will get the hang of it. I feel like don't worry if like you get an ECG and you don't know what's wrong with it. Just use like the framework, and then like you'll slowly start to spot things, and you'll be able to pick up on what like the problem is. Also to remember like the clinical context. So if the patient has like pain, like chest pain, or like if they're really unwell, it can help you with your diagnosis. And then other traces that I think are quite like common that they might test you on, the ones listed here. So like ventricular tachycardia, ventricular fibrillation, atrial fibrillation, supraventricular tachycardia, atrial flutter, the different types of heart block, Wolff Parkinson's White, cardiac tamponade, and Tutors de point. And there are other ones, but I think those are the most common. Yeah, I think I have like 3 questions.
Okay, so before we go on to ABGs, if you guys join the Menti again.
So if you just look at the ECG and then I feel like ECGs are really hard. But I think especially in like 4th year, like getting the final diagnosis is only like 1 mark or 2 marks or something.
Yeah.
Like half of it is like going through like the structure of how to interpret one and like going through all of that. You just press it. Can I just press that? Oh.
Wait for
To show what's the right answer.
Oh, wait. Sorry, guys. Oh, you haven't put it on there.
Put what? Oh. Okay. I think the right answer is sinus bradycardia.
Yeah.
Just because there's no prolonged PR interval, which is what first degree heart block would look like. There's just like a big space between each heartbeat, which means it's just bradycardia and it's in sinus rhythm. Oh, I didn't. Did I put the answer on this one?
No.
Oh, okay. Okay. Well, the answer for this one is Tutors de points. So this is actually a type of ventricular tachycardia, except it's
Polymorphic.
polymorphic. So the amplitude like changes. I don't know. Don't know whether. Oh, that is just awful. Okay, whatever. We show you at the end. It just like the amplitude's like going up and down, and it's kind of alarming because what it could do is it can turn into ventricular fibrillation, which is very bad, and you'll need to start like your advanced life support in terms of getting, because the heart's not pumping properly anymore. So yeah. You put the answer on this one.
Oh yeah, I did.
Yeah, so the answer for this one is atrial fibrillation, because see that it's got there's no clear P waves and it's irregular. In terms of the other options, atrial flutter is like what they call the sawtooth baseline. So it's it's not just like a bunch of squiggles where the P waves would be. It's like a rhythmic kind of abnormality. And then Wolff-Parkinson's white would be where there's like this slurred upstroke called the delta wave. And pulmonary embolisms they teach you on PassMed that it's like S1, Q3, T3, which is like when there's a S wave, where there's a big S wave in lead 1, a Q wave in lead 3, and
T wave.
an inverted or something.
Yeah.
But actually, in the majority of times, you'll get a normal ECG. You'll just get like sinus tachycardia for pulmonary embolism. I think that's it.
Okay. Yeah, that is the case. Okay, so we'll go back to sorry, the computer's just so slow. Okay, so just ABGs quickly. ABGs are really helpful to do in A&E, and they become kind of a core part of your A to E assessment that you guys will probably go through at the end of the term if you're on Mod A or later on in the year. And they're really important because they can tell us how sick a patient is. And this is kind of, I've just put on there what kind of things you can get on the ABG, and also the lactate as well, which is really important for things like sepsis. But one thing to bear in mind is that the way you interpret the ABG can change depending on whether the patient is on any oxygen delivery devices or not. So the FiO2 is the percentage of oxygen that a person inhales. And so if I just go to the next slide. So on room air, around 21% is oxygen. And so we work out the expected PO2 by minusing 10 from the FiO2. So in this case, the FiO2 would be 21% on room air. So minus 10 would be 11. And so normal is above around 10 kPa. And on the side, I've just put kind of the general percentages of like the oxygen for different types of delivery devices. So for example, if a patient was on FiO2 of 60, so for example with a non-rebreathe mask or something, the expectant PO2 would be 50. But so you can see how sick a patient is if their FiO2 is lower than, if their PO2 is lower than that, sorry. So generally we consider hypoxia to be less than 10 kPa, and severe hypoxia with respiratory failure if they are less than 8. So going on to carbon dioxide. So I'm sure you all know that it's a byproduct of aerobic respiration and it makes things acidic. So if a patient is hyperventilating and they're blowing off a lot of their CO2, then their blood will become alkalotic because there's not enough CO2 in the body. And conversely, if they are hypoventilating, they're not breathing off enough of their CO2, so it's going to be kept in the blood, and that's going to make the patient acidotic. So if there's changes in the pH that are coupled with changes in the CO2, that could indicate more often a respiratory cause rather than a metabolic cause. Quickly, just type 1 respiratory failure is hypoxia with normal CO2 levels, and type 2 respiratory failure is hypoxia with high CO2 levels. So an easy way to just remember that is just that type 2 has 2 things wrong with it. So the bicarb, it gives you an idea of the metabolic picture, and it helps you differentiate between respiratory or metabolic causes of the pH imbalance. So like I put on the slides, the bicarb mops up the hydrogen ions. So if there's more bicarb, then there'll be fewer free hydrogen ions, which means that the blood will be alkalotic. Whereas if the bicarb is low, then there's more free hydrogen ions, so it's going to be acidotic. again, if there's changes in pH that are coupled with changes in bicarb, then more often than not, that's a metabolic cause. And lastly, just compensation. So it can be metabolic compensation or respiratory compensation, but a way to differentiate between the two is that respiratory compensation happens a lot quicker. So in an acutely unwell patient, they might be hyperventilating, and that's part of their respiratory compensation to balance out their pH. Whereas metabolic compensation is dependent on the kidneys adjusting. So that's going to take a lot more time, probably a few days. And you can tell between partial and full compensation, because if there's a normal pH, but there's abnormal other values like the bicarb and the CO2, then this is going to be full compensation. Whereas if there's an abnormal pH with the abnormal bicarb CO2, then this is partial compensation. Okay, so this is just an example. Does anyone want to have a go at interpreting this? Or, yeah. What do we think of the pH? Is it acidotic, normal, alkalotic?
No.
Yeah, so it's acidotic. And what about the CO2? High, low, normal? Okay, so it's high, so it's hypercapnic. And so then this explains the acidosis, because there would be, there's a respiratory cause. So high CO2 retained in the blood causes acidosis. And with the bicarb, there's high bicarb, and so that indicates that there's some kind of metabolic compensation. But because the pH is not normalized yet, then we can say that this is partial compensation. So overall, this is respiratory acidosis with partial metabolic compensation. Okay, and with the second one, does anyone want to try? Okay, so the pH is alkalotic because it's obviously higher than the normal range. The CO2 is again high at 6.5, so hypercapnic, but this doesn't quite match with what you would expect. So you can kind of see that this would be a metabolic cause, and that the hypercapnia is probably because of some kind of compensation. And then the high bicarb would explain the alkalosis, because it's mopping up the hydrogen ions, so there's it's going to be more alkalotic, and so then it would be a metabolic cause. So then we could say, again, because the pH isn't normalized, it's metabolic alkalosis with respiratory partial respiratory compensation. Okay, so we've just got one case to finish off with. If you guys can go to the Menti again, and we'll get it up, is kind of just to tie in what we've gone through today. Okay, so 26-year-old woman that's come in. This is based on one of our OSCE stations for our fourth year exams.
Exactly what we got for one of our 10-minute stations.
Very, very similar. So a 26-year-old woman with a BMI of 28, brought in by ambulance from her GP to the emergency department, past history of 4 to 5 days of shortness of breath, central chest pain, which is worse when she coughs. And on examination, her pulse is 120, BP is 96/60, chest auscultation reveals scattered wheeze and a mild fever of 37.9. No past medical history other than use of the combined oral contraceptive pill. She's a frequent flyer and just came back from holiday from Thailand. So does anyone want to suggest any investigations that you would like to perform, or how you would go about approaching this patient?
It's probably the ones we were talking about today.
Yeah. So you would probably, using an A to E approach, which it will definitely get drilled into you later on this year. You would probably want a chest X-ray, ECG, and ABG as your kind of basic. As soon as you see the patient, unstable observations, probably want to get those.
And like bloods and stuff like that as well. Yeah. We're going to focus mainly on just the ones we talked about.
Okay, so just to start off with this ECG, what do you guys think of this ECG?
It's not ECG.
I mean, this chest X-ray, sorry. Does it meet the right requirements that we talked about? So that's rotation, inspiration, penetration or projection, exposure. Okay, so I guess it's a bit of a mean one, but it was slightly underexposed because the apices of the lungs have been cut off. So ideally you would want to see the apices and a bit of the trachea to make sure that you can get a full view. Okay, next one. Okay. Okay, so this ECG actually, this chest X-ray actually is normal. The mid-zone opacification is just the hilar. That is probably what's kind of throwing you off. Hyperinflation, if you look at the anterior ribs, there's like 1, 2, 3, 4, 5, 6. It doesn't look too hyperinflated because the diaphragm would usually be flattened as well at the bottom, but there is quite an acute angle, the costophrenic angles. Okay, yeah. So all in all, I would consider this would be a normal chest X-ray. So moving on to the ECG now that the patient would have got.
Yeah. So your ECG's come back, and you've done all the patient details, and it was just taken like 10 minutes ago. And then first thing you want to look at is the rate.
Okay, yeah, so do you want to go through it?
Yeah, so the correct answer is 162, because
usually it's quite easy to do the 6 times the number of QRS complexes, especially when you get kind of flustered in an OSCE and kind of trying to count in between, figuring out if it's regular or irregular.
They usually give you a calculator, I think, so you can just type in the calculator. I always think it's easier to count the rhythm strip. So I think there was 27.
Yeah.
So 27 times 6.
Yeah.
Is 162. which is tachycardic.
Yeah.
Yeah, and then so the rhythm, we can look at the rhythm, and I'd say that's sinus rhythm.
Okay, yeah, it is normal.
Oh yeah, it is normal.
Yeah.
So left axis deviation would be left leading. So lead 1 would be positive, and lead 3 would be lead AVF would be negative. So in this case, they're both positive, so it's normal. And then we want to look at the shape of the P wave. So is it normal, is it biphasic, or flattened, or tall? Okay, so I think majority of people have gone with biphasic. So looking at the ECG, because it is tachycardic, I think what people think is biphasic is actually the T wave and the P wave kind of being really close together. So it's actually a normal P wave. It's just because the heart is beating really fast. So finally, what do we think is the diagnosis from this ECG? Yeah, so I think most of you are right, so it's sinus tachycardia. I don't think I saw any ST elevation. But it's quite dramatic when it's a STEMI, and also it would be in like that territory. So it wouldn't just be in like a singular lead, it would be in like that area.
Okay, so yeah.
Now you've got a normal chest X-ray, and you've got your ECG, which is just sinus tachy, and then now your blood gases come back.
So I haven't got the normal values on here, so I'll just tell you. pH is high. O2. Oh, they're there. Okay, that's fine. Okay, so let's just go through it. My laptop wants to. Okay. Yep, so it is respiratory alkalosis. So we can see that just because the pH is higher than the normal values, which is the main thing we're looking at. and because the bicarb is within the normal range.
Yeah.
And the CO2 is low and the O2 is also low. So because the bicarb is in the normal range, we can kind of know that it's respiratory and not metabolic. And then because it's higher than the normal range, then it's alkalosis. Okay, so last one. Or second last one. So yeah, so this would be type 1 respiratory failure. Because the O2 is low, we know that it's some kind of respiratory failure, but because for type 2 respiratory failure, the CO2 has to be high. So because it's not high, we can consider it as type 1 respiratory failure. So yeah, what do you think? What do you think the top differential is? Okay, yeah, so it's a PE. So yeah, like we said before, our ASCII station from this year was based on this, and instead of chest X-ray interpretation, we had to do an ABG. But yeah, it's just something to bear in mind because I think in past med and things like that, they do point out things that can come up in like an ECG or something like that, that would indicate towards a particular diagnosis. But often, for example, in a PE, it is just sinus tachy, and it's rare to get the S1Q3T3 sign. So yeah.
So I think it's like because you get like a brief history as well before you go in on the brief. I think like the main thing was like, oh, she's been on a long flight and she's on the pill, which is, I think, what gave it away for me, because otherwise all the other signs were kind of not that specific.
Yeah, so I think it's important to just make sure when you read the brief before you go into your OSCE stations, just remember that in mind, and kind of look at all the investigations in the context of the patient's history, because it can make a real big difference, especially when you get a little bit flustered in OSCEs and things like that. Referring back to the brief can really help. So we've just popped a feedback form in the chat. Hopefully you guys can see it. It'll be really helpful if you guys can fill it out and just give us some feedback about how we can improve these sessions in the future. Does anyone have any questions? Yeah, please feel free to unmute or use the Q&A box.
In terms of the blood gas, it's like respiratory alkalosis is because of hyperventilation.
Yeah.
I can't say it.
Hyperventilation.
Yeah. So she's blowing off all her CO2, which is causing respiratory.
Yeah, I should have mentioned that. Yeah, so that's why it's alkalosis.
But not always. Sometimes it's just normal as well in PEs.
Okay, so I think that's all we have. If no one has any questions, thank you so much for joining, everyone. And yeah, don't be too worried if there are things that you can't figure out yet. It will kind of all fall into place as the year goes on.
Thank you.
Thank you.